Hello, I am David Anthony, and I am here to introduce you to our presentation, which we are calling Who Are We and Where Are We Going? Aligning the National Clerkship Curriculum, the NBME, and Aquifer Family Medicine's learning objectives for enhanced curricular mapping. And this talk, which is intended to be a lecture discussion, is something where we are hoping to get your feedback and your thoughts about how best to align these three important products that are related to family medicine education. And so we are at the end going to invite you to respond to a brief survey through a Google form. And briefly, just who we are. I am, again, David Anthony. All five of us have served as clerkship directors in family medicine at our respective institutions. And I serve currently as the Aquifer Family Medicine Editor-in-Chief and Senior Director. Jason Chao serves as Aquifer's Assessment Lead, and Katie Margo serves as the Curricular Lead for Aquifer Family Medicine. Annie Rutter has served as the chair of the National Clerkship Curriculum Editorial Board, and Robert Hatch has served as the head of the NBME Task Force on the Family Medicine Subject Exam. One brief disclosure is that I myself and Drs. Chao and Margo all work on the Aquifer Family Medicine Editorial Board, and we do receive honoraria for that work. Aquifer is a federally recognized not-for-profit health professions education organization and is an STFM conference partner. Just briefly, the outline for this presentation is to talk a little bit about who we are. We're going to introduce the NCC and introduce Aquifer Family Medicine, and then introduce a little bit about the Family Medicine NBME exam. And then we're going to dive into where we are going and introduce you a little bit to Aquifer's current curricular mapping project, which was the instigator for this presentation, and then talk about the implications of what we found in our mapping efforts, and get into a little bit of a discussion about what is core in family medicine education, and can we have a core group of topics, or how broadly do we want to define what our global list of learning objectives are. And then related to that, what are the implications for evaluation? And so that brings us to who we are. And I'm going to now introduce Annie Rutter, who's going to tell you a little bit about the NCC.
Hello, everyone. My name is Dr. Annie Rutter, and I'm the Director of Medical Student Education and the third-year Clerkship Director at Albany Medical College in Albany, New York. I also have the pleasure of serving as the STFM Medical Student Education Chair, as well as the Editorial Board Chair for the National Clerkship Curriculum. Many specialties have developed a set of goals and objectives to serve as a guide for their departments and clerkship directors across schools of medicine to help them determine what a student should know and accomplish after completing a clinical experience within their discipline. Under the guidance of STFM President Scott Fields, STFM undertook this effort for family medicine. In 2008, the C4 Task Force was convened. This task force was convened by STFM, but included representation from AFMRD, AAFP, ADFM, and FM cases. That group devised a list of common and important patient problems frequently encountered in family medicine offices. In addition, they devised goals and objectives in order to show and demonstrate what should be accomplished by family medicine clerkship students. The curriculum was created and then disseminated by STFM. Shortly thereafter, the National Clerkship Curriculum Editorial Board was established. This group was charged with maintaining the website that housed the goals and objectives, but also decided to add supportive content, which included educational methods, assessment strategies, in order for clerkship directors to be able to carry out this new curriculum. More recently, peer-reviewed best practice curricular elements have been added to the website. After approximately 8 years, the first revision was undertaken, and it was published in 2018. When the STFM National Clerkship Curriculum was first being devised, there were several questions that the group needed to answer. The first was the why. There were several reasons for this, and they were both educational and political. Educationally, it was felt that the attributes of family medicine should be taught to all medical students, that family medicine is foundational to the healthcare system. There were political motivations as well, and this included the opportunity for clerkship directors and department chairs to use the NCC to negotiate for resources within their own institutions. It was also felt that an NCC would help with LCME self-studies. So what were we trying to devise? We were trying to think about a family medicine educational experience for all students, a clinical opportunity to see what family medicine is all about. But how? We know that clerkships are different. They occur in different times in the curriculum, they're longitudinal or block, and they're integrated. How is this going to be accomplished? And then the question of core versus not core. What should be included in the NCC? Is a diagnosis a discipline's responsibility? Is it an approach to care? What makes family medicine unique, and how is that going to be captured within the NCC? When the C4 task force devised the first version of the National Clerkship curriculum, they divided it into 5 sections. These 5 sections have remained through the first revision published in 2018. The first section is the principles of family medicine. What are the tenets that we hold dear as family physicians? How do we approach the care of patients and communities? The next 3 sections all discuss clinical content that should be covered during the course of the clerkship: acute care, chronic disease, and health promotion and disease prevention. And finally, the 5th section included the role of family medicine within the healthcare system. As you can see by these 5 sections, the National Clerkship curriculum is more than just a list of diagnoses. It teaches students how family medicine fits into the greater healthcare system. As clerkship directors, we know that we aren't teaching a room full of future family doctors, and yet the importance of our specialty, how it works, what it's capable of, and how we work to take the best care possible of our patients is an important part of what we teach all the students. When completing the newest version, the 2nd edition of the NCC published in 2018, the editorial board grappled with difficult questions about the specific content. We knew that by including certain diagnoses, we may be asking some clerkship directors to reach a standard that would be impossible to attain due to the structure of their individual school's curriculum. Maybe it was due to lack of time, or just because, quote, chest pain is covered by internal medicine rather than family medicine. However, by leaving certain diagnoses out, we were diminishing the worth of the clerkship. Could everything in family med be relegated to another specialty? How would we keep our content and curriculum unique and relevant to all students and institutions without asking individual clerkship directors to put the entire medical school curriculum on their own shoulders? What is core to family medicine? The section on principles and role of family medicine helped to make the national curriculum irreplaceable, but what diagnoses should be included? The 2nd edition built on the first, using NAMCAS data for frequency of visits in ambulatory care.
Thank you, Annie. And again, I'm David Anthony. I'm now going to tell you briefly about Aquifer Family Medicine, which used to be called the FM cases. Most of you are probably quite familiar with this. It is a set of 40 virtual patient cases that was designed to broadly cover the content of the NCC and to be used in family medicine clerkships as well as other health professions education settings. And they were originally written in around 2008, and they were developed in parallel with the development of the first round of the NCC. And each case was developed with 8 to 10 learning objectives that were written separately from the original drafting of the learning objectives of the NCC, although they were trying to be mapped more or less together, but they often use slightly different wording of the learning objectives. And then within each case, you have, of course, the narrative of the case that is presented, but also the core content, the dry medical content that is presented in discrete bursts, which we call teaching points. Now, Aquifer also was in its original charge in collaboration with STFM, developed a family medicine final comprehensive exam. And the decision was made from the get-go to have one comprehensive exam and not to make smaller subject exams with sets of cases that didn't cover all 40 cases, with the decision to go with one large core exam that covered the full body of content. And that is going to be available through 2022. Aquifer has made the decision that since we are not really a test development organization, we are really a content delivery organization, that we're going to shift away from testing and shift towards test-enhanced learning and the development of coaching tools for teachers to help in the development of master adaptive learners. And in a brief plug, I'll let you know that we have a separate presentation about coaching for master adaptive learners that I'd encourage you to take a look at.
Hi, I'm Rob Hatch, and I'm going to talk about how the National Clerkship curriculum has shaped the NBME subject exam, a lesson we learned about the curriculum from the NBME exam, and also show a little bit of data on how case-based study is a great way to prepare for the NBME exam, which potentially could be quite important as more schools switch over to using the NBME exam. By way of background, I want to mention that I was part of the committee that developed the NCC, and after that I chaired the NBME task force which oversaw the family medicine clerkship exam, and so I have experience on both ends there. So traditionally the NBME exam was not a very good fit with our clerkships, but in 2009 the NBME responded to our concerns by forming a new task force just to write items for the family medicine clerkship exam. No other specialty had that, and the NBME did that just to help us get a good exam for our clerkships. All members of the task force are family medicine educators, and nearly all are very active with STFM. Different medical schools wanted different things emphasized on the exam, and the NBME accommodated us yet again by creating something just for us, a core section with the option of additional extra modules. The extra modules you could get were OB, so you could order 10 additional OB items that were more challenging than the content that was on the core, 10 extra chronic care items, or 10 extra musculoskeletal items. Once those versions were rolled out, schools voted with their feet. About half of schools said the core is just fine and that's all we want to use. About half ordered core plus extra chronic plus extra MSK, and only 2 or 3 ordered the extra OB module. And by way of perspective, that's well under 5% of all the schools wanted to use the extra OB module. So the NBME actually had to stop offering it. So this is what I mean about a lesson from this exam to all of us. There are people who advocate for OB, but voting with their feet, very few schools wanted to test on it. Almost no schools used either just chronic or just MSK, and so now there are only 2 options available, the 80-item core or the 80-item core plus chronic plus MSK. The NBME views the NCC as the best guide to appropriate content for the family medicine subject exam, and task force members are told to use that as the primary guide. Once items are written, every new version of the exam is reviewed by 4 family medicine clerkship directors plus the chair, and reviewers are asked to assess the appropriateness of the items and also to ask if the exam overemphasizes or inadequately covers any areas. In 2014, I reviewed a draft of the exam to see how well it matched with the NCC, and what I found was that out of 58 acute care questions, it covered 20 acute presentations in the NCC, and there were only 2 areas that were not covered, pregnancy and vaginal discharge. And within chronic care, there were only 3 areas that were not addressed. I forwarded that information to the NBME, and the next time instructions came out for item writing, you will notice that Category 11, vaginal discharge, and Category 13, initial presentation of pregnancy, were 2 areas that the NBME specifically asked item writers to address. So the clerkship curriculum was fed back to the NBME, how it matched, and they specifically asked people to fill in areas of the NCC that we were missing. And I want to close my section by citing 2 bits of data. This was a study presented by Howard Sussman at STFM several years ago. And in his research, he found that the percent correct on the FM cases exam correlated very highly with the score on the NBME exam. So studying those cases is a great way to prepare for the exam. And finally, this is an earlier study by Gary Shokar, which shows that the number of web-based cases completed is associated with a higher score on the NBME exam. So to wrap up my section, I want to mention that the NBME is closely aligned with the NCC. that case-based study is an effective way to prepare for the NBME exam, and therefore the better the Aquifer cases match the NCC, the better they will prepare students for the NBME exam.
Thank you, Rob. And again, I'm Dave Anthony, and now I'm going to start talking about where we are going and about the project that sort of started this whole presentation. So the Aquifer Curricular Mapping Project is an Aquifer-wide effort, but I'm going to talk in specific about the family medicine aspect of this mapping project. And it was really inspired by Aquifer's transition away from the summative final exam to having formative test-enhanced learning products. And the goal for Aquifer Family Medicine is to make sure that each test-enhanced learning item, and let me define that briefly. So if you think of a test-enhanced learning item, what you're really looking at is a multiple choice question that's developed for formative assessment rather than for summative assessment. So each of those items is mapped directly to an Aquifer teaching point within a case, and that then each Aquifer teaching point is mapped directly to one of the Aquifer learning objectives for that particular case. And then in another step, each of those Aquifer learning objectives is mapped directly to one or more STFM NCC learning objective. And we already know from what I've told you before that the NBME exam items all map back to NCC learning objectives. And so therefore we'll have a nice, hopefully, unity of all of these learning objectives, and that clerkship directors will know if they want to find where something is taught, they'll be able to look at Aquifer and figure out exactly where the teaching point is. Students could look, do a test-enhanced learning module and figure out if they're not doing well on a particular topic, where in Aquifer they could find that content and make sure that they are learning what needs to be learned as part of the NCC national curriculum, and therefore also be preparing for the NBME final exam. And let me just tell you that this mapping project is hard work. And this is just a spreadsheet that shows you the work from just one of our Aquifer cases. And you can see on the left, there are all the teaching points from that particular case. And here are the learning objectives to which we have mapped those individual teaching points. And sometimes they map to more than one learning objective. And over in column G, you have all of the learning objectives for the case, the original learning objectives, and then we're again rewriting them so that they better map to STFM learning objectives, just to make sure that the wording matches up. And then you can see all the way to the right, the STFM learning objective to which it maps. And we have them numbered in a separate spreadsheet, and you can see there's a large number of them. We're up over 600 in this slide alone. And what we have found in doing this process, there's a few things that are very interesting. And for one, there are a few things that Aquifer Family Medicine covers, in some degrees pretty extensively, that are not actually part of the NCC. And just a couple of examples from acute presentations are thyroid disease. So we have a patient with hyperthyroidism, and we have a patient who has hypothyroidism, and we teach about both of those conditions. We actually have two cases that present with a patient presenting with palpitations, and palpitations is not one of the acute presentations that the NCC asks clerkships to cover. And then there's a large block of women's health content, particularly contraception, which comes up in several of the Aquifer cases, but is not actually listed in any of the NCC learning objectives. And sexual dysfunction is another example. And there are other examples other than these. These are just some nice examples of this. Separately, there are also things that are in the NCC that Aquifer does not cover. Notably, actually, the principles of family medicine. So one of the broad categories of the NCC is that we are to teach about the principles of family medicine, and that is modeled to a fair degree in the cases, in actually how the physicians and the hypothetical students who are interacting with the hypothetical patients, how that is modeled does demonstrate many of the principles, but it is rarely directly taught. And one acute presentation, as an example, is NCC wants clerkships to talk about chest pain, and there is not a chest pain case in Aquifer Family Medicine. We actually have two palpitation cases, as I mentioned, and we do teach about cardiovascular disease and about stress testing, but not directly about the differential of chest pain. And so all of this work has gotten us to think about where we should be going at Aquifer and in relation to the NCC and the NBME. And so I'm going to turn it over now to Katie Margo to sort of get you to think a little bit about what our learning objectives should be and how to organize them well, and what should be core and what should not be core.
Hi, I'm Katie Margo, Associate Professor Emeritus at the Perelman School of Medicine at the University of Pennsylvania, and I'm on the editorial board of Aquifer Family Medicine. I'm going to discuss some of the dilemmas we are presented with based on what you've just heard. First, to maximize legitimacy and usefulness, Aquifer's Family Medicine's goal is to have the Aquifer learning objectives match the National Clerkship Curriculum learning objectives. However, in doing our mapping project, we have found gaps on both sides. There are NCC learning objectives which are not in Aquifer, and vice versa. We think that it would be helpful to address this discrepancy, but it's not clear what the best process to do that would be. The NCC was just revised in 2018, and there hasn't been a plan to relook at it for a few years. Aquifer is constantly updating cases and would like to get them in sync with the NCC sooner rather than later, especially if we want schools to use our cases to prepare for the NBME subject exam, which, as you heard, tracks the NCC curriculum. So in order to address gaps in the NCC steering group would probably need to reconvene, but that would have to become an STFM priority. To address gaps in Aquifer learning objectives, there are a number of options. We could write more cases, but that's a huge amount of work and is unlikely to happen unless it's the only alternative. We could add teaching points to address the missing learning objectives in current cases, which makes the cases longer, and nobody really wants that. We could create separate modules, for instance, on the principles of family medicine that pop up at appropriate times during a case. During our learning objective mapping initiative, it was shown across all of the Aquifer cases, including pediatrics, internal medicine, geriatrics, and radiology, that family medicine has by far the most learning objectives of any course. This raises the question of whether there should be or could be core objectives for family medicine. Whether we should identify a core set of objectives has been controversial since NCC's inception. One reason not to designate core topics is to help family medicine clerkship directors who want more time for their clerkship or even to start a clerkship. In both cases, the full list of learning objectives demonstrates the breadth and complexity of what we do as a discipline. The list of the learning objectives was created through STFM, the primary national family medicine education organization, which gives it legitimacy and power and doesn't peel off topics that we care about like OB and PEDS. On the other hand, the downside to not having core topics is that it's very difficult to cover the whole NCC in, for instance, a 4-week clerkship. It could be very helpful to clerkship directors to have a core set of learning objectives, which would be easier to ensure coverage of, filling in other objectives as needed in a particular school's curriculum. Deciding what should be core and who should be the decider would not be an easy undertaking and would have to be decided based on a balance between enough breadth and identifying what is key for family medicine to cover. This balance would likely also depend on what the rest of the clerkship curricula cover on a school-by-school basis. This might mean that certain topics, GYN, PEDS, OB, could be lost to family medicine. Alternatively, if something is in the core, it might be easier to keep it in the family medicine curriculum. So you see, this is a very complex situation, and we need great minds to help us think it through. We would greatly appreciate you listeners' thoughts on these topics. We're putting a QR code with a link to a survey at the end of this talk and invite you to share your thoughts with us. Thank you.